I'll let you take it away. Thanks for making it.
Hi, everyone. We're going to go ahead and get started. I'm going to do the housekeeping slides. And Jalen, will they pop back up? Okay. So really quick, did you guys all get the Wi-Fi in case? Okay. You got it? All right. Thank you. Yep. The next one, hold on. See, Abiola, I'm going to make sure I figure out how to do this. How do I? I'm probably going to press one button and it's going to go forward. Oh, so you just,
Right.
Oh, there you go. Okay, you just press the center.
Yeah.
Okay. All right, now we're ready. Okay, so if you haven't, we would like you to sign in, please. That was up at the reg desk, or here is the QR code. If I flip past this and you didn't have time, then they're posted all around in little plexiglass things for you to be able to sign in. You guys good? Okay. The next one's the pretest. This would be if you're going to claim credits. We would like you to take the pretest. You good? Okay. So our presenters today, we've got Dr. Gotti and Dr. Ibrahim. And all of this information, by the way, is in your guidebook that you received when you checked in, but I just threw it up here for quick reference, and we wanted to point out a few things. I listed their financial report disclosures right below that on this slide. Also in this booklet, you'll see that it references the website. On the website is where you can also find a full list of all the faculty disclosures for our other sessions as well. Here's our agenda for today. So we're going to have Abiola is going to come up first, and then BK is going to come up. We'll have a break. We'll have another presentation from BK, and then Abiola and BK are going to have a nice open discussion, which will be lively dialogue for everybody. Also, please feel free. This is for informal. Just speak up if you have a question. Everybody can hear you. We do have people, about 12 people registered to attend online, but sometimes we have more than who registered after we send the link out. So we do have online participation. Just so you guys know, it's not video, Abiola, it's just audio, but they can hear the whole room. And then they'll be able to see the slide, just so you know their dialogue. And I'm going to pay attention to chat to see if people ask questions. And then we want to say thank you to our exhibitors and our sponsors. And let me go ahead and here. See how organized I am. Okay, how do I go to full screen? And we're recording. Okay, we're good. All right. And here's Abiola. And be careful, there's wires right here, guys. Oh. I'm gonna be the one that trips.
All right, thank you very much. Thank you everyone for showing up today. Thank you to our sponsors. Thank you for attending and taking time out of your busy summer. I hope everybody's summer is busy, or we have something planned for summer. And we will be spending the next 1 hour talking about updates from ASCO. So right now, these are my disclosures. And I would talk about, first of all, I'm talking about metastatic hormone receptor positive breast cancer and triple negative breast cancer. So during the last ASCO, I think most buzzes was from the hormone receptor positive breast cancer space. And we were able to communicate with ASCO, and this was the best of ASCO that we got. And I'm actually working personally on Best of ASCO in Africa, which this is just a sidebar. I'm actually chairing that initiative and addressing how this innovative therapies is going to be going to lower resource settings. So one of the things I'm going to be doing today is, apart from talking about the data, I will try to put it in clinical context, right? Because it's not only us talking about the innovative therapies and what have we. The question is, when there's an innovation, right, how do we integrate it into clinical practice? I will tell you as a physician, I mean, you know what the data is, but then how do you actually start changing the way you practice in your center to be able to accommodate the latest data? And how do you do that quickly? All right, so again, we are going to be talking about updates and innovation and in the hormone receptor positive space. And then we'll be exploring the cutting-edge advances in therapies and technologies and talking about the recent trials that was presented in ASCO. And we'll talk more on the oral sets and the therapeutic agents that has been reshaping patient care. So one of the unique factors in my practice is that 70% of my patients are minority patients, and majority of my patients are from low socioeconomic status. So what that means is that whatever this is, it has to be able to be relatable in clinical practice. I won't go ahead and talk about, oh, there's no racial representation, or there's more of cherry picking in where the studies was done. We already know that. We've talked about that. And I hope that we are actually doing some things actively to address that. But as we see, and I hope that with all the interventions we are doing in different phases, we hope to see the reward of our intervention probably in a couple of years, hopefully soonest. But as we are waiting on that, we have to look at what are we going to do in the real context, in real life, and real life meaning today. My clinic is on Thursdays. I'm trying to add a Monday clinic. So what that means for me is that my next Thursday, how do I integrate it in the patient care? How does VK's clinic is Thursdays and Wednesdays? How does it integrate it in our practice immediately? Now, we at UIC, one of the other strengths that we have is that we are also well linked to the community. So the question also is, how do we get this innovations, right, the new update, and how do we integrate it in the practice of our patients, and especially with the patient population that they serve that has not even been part of this, but then we have to be able to bring that care to their doorsteps. All right, so from when the patient has metastatic hormone receptor positive disease, especially de novo, historically, we know, and it's so funny because I remember when the palbociclib was approved, I believe 2016 or 2015. Oh my God, it's so old. Because I remember then I was a first-year fellow at University of Chicago, and we had to learn it, you know. And now you think about it, and I felt it was yesterday. No, it's not. It's like over 10 years. Wow. So I think I'm getting closer and closer to a facelift is what it's telling me. All right. So we know what the backbone has always been. You know, patient comes in with metastatic breast hormone receptor breast cancer. And the first line of therapy has been CDK4/6 plus hormone receptor and AI, depending on if the patient is premenopausal or postmenopausal. If it's premenopausal, you move that patient into menopause, you give ovarian suppression, and then you add that. You know, the interesting thing was initially the first studies for all the CDK4/6 inhibitors that was done, most of them were in the postmenopausal space. And then it raised the question of, oh, what about the premenopausal patients? And then ribociclib study was done in the premenopausal space with ovarian suppression and AI, and we found out that the data was also translatable. So for a good couple of years, that was the first line of treatment. And the fun fact is, currently NCCN guidelines is in progress. So things are going to change very soon from what we see today in NCCN guidelines. All right. So we know that CDK4/6 inhibitors have been able to improve PFS and OS, but the question is again sequencing of it. The Soya trial was already done, and what the Soya trial did show was that I'm just giving a historical. I'm going to get to the ASCO update. Soya trial showed that even if you decide to do endocrine therapy first before you go to CDK4/6 inhibitor versus when you do CDK4 first before you go to endocrine therapy, it's almost equal, right? Then, depending on where you are or what you want to do, you can start with endocrine therapy first before you move on to addition of CDK4/6 inhibitor. Then the next question is, okay, if a patient progresses on this first line, it was first line for a minute, but if a patient progresses on first line, what do you do? In my practice, I kind of changed the dance partner, right? Some people actually changes the dance partner. If you're doing anastrozole with ribo, you might change it and move it to fulvestrant and abama, depending on what. And for me, before I move on to the next thing, like the PIK3A, where I'll start thinking about hyperglycemia, I try to make sure that I have maximized the CDK4/6 in the space of the first line. All right, so chemotherapy used in this group of patients. I don't know. I struggle with chemotherapy in hormone receptor positive patients, especially if they are highly hormone receptor positive. Because in my experience, I've always thought that patients, I mean, the teaching is when a patient is in visceral crisis is when we do chemotherapy. But the point when a patient is in visceral crisis, we know that the outcome of that patient is less than 3 months. So do I want to add chemotherapy given the whole side effects of it to push the patient off? And I was talking to, who was I talking to? Like we talked about this, but we're talking about, well, even if we say we want to add CDK4/6 inhibitor, all these innovative therapies at the point where a patient is getting visceral crisis, especially when the patient is on admission, the approval is the issue. It would not get approved. Most payers are not going to pay for these therapies, especially when the patients are inpatient on admission. Right? They expect the patient to be in the clinic before this gets approved. Maybe that's going to be something where you have to start thinking about as far as getting approval or maybe getting a bridge drug before the patient comes to see us in the clinic. That's in the chemotherapy space. I think that as time will go on, we will see that chemotherapy may not have any activity, especially when a patient is highly positive with hormone receptor positive, or when a patient, if you do a mama print, they are more likely to be luminal A, not necessarily luminal B to benefit from chemotherapy. All right, so now with the new evolving targeted therapies, I want to believe that, when you get a patient that is metastatic, we are getting to a point whereby instead of you just putting the patient on the CDK4/6 plus AI or just doing an AI first, we are getting to a point whereby we might have to start doing a molecular profiling first, right? Because things are changing. You want to determine what kind of mutation does the patient have. If the patient has ASR1 mutation or de novo, I mean, it's not as common. Or if a patient has a PIK3CA and then a BRCA mutation again. And then most importantly, you want to know the timing at which the patient progressed. So if it's a patient that was locally advanced to begin with, and then they progress even on treatment. Now that is a group of patients where the therapy might be different. Or if a patient, after like 5 years or 10 years of endocrine therapy and they are off it and less than a year, they have a metastatic disease. Again, that is a group of patients that you might want to start thinking about, well, do you just want to do a CDK4/6 inhibitor because it's not a de novo, or what else do you want to do? I think we are beginning to get to a point whereby once we see a patient that is metastatic, before we start putting the patient on any kind of systemic treatment, we have to do some molecular profiling and start thinking about how do we actually address the mutation. Again, we are moving away from chemotherapy to more of targeted therapies, and I think this is the way we are going to be thinking about it. Can you hear me though?
See if we can get some sound for you.
So I'm not loud enough?
Sound, and they don't have it in the room. We have some clicking in the air. So I was gonna have you project it, but they said they can't add sound. So can you speak up a little bit?
Oh,
You
okay.
mind?
I'm so sorry. You didn't hear me over there? Just a little bit. Oh, okay. Now I can be loud. I can be loud. Okay. Sorry about that. All right, so should I start again from the beginning? I'm joking. All right, so now we're going to be looking at molecular profiling, summary of it, the gist of it. A patient comes in with metastatic disease. We are getting to a point whereby it's no more one size fits all. You will get to a point you have 3-4 things to choose from, depending on the patient's story or the way the patient presents. And the way I tell my patient is this, especially when they tell me, well, in a cookout, this person has taken this. Why am I not doing that? I'm like, because your cancer is unique. So we are now in precision medicine, whereby we have to tailor the treatment to a patient. More work for us because we have to study more now. It's not that easy, which is great, right? So, and then it takes me to the Innovo trial. Now, the Innovo trial is one of the trials that I find interesting because this trial actually has changed the way we treat our patients. Normally, you see every patient coming in metastatic stage 4, whether de novo or not, or progressed locally advanced or progressed on treatment. But for this group of patients, we see that this PIK3 mutated patient, from the beginning, are we going to actually look at the molecular profiling for this patient? What group of patients must you look at the molecular profiling? So for this study, these were patients that de novo metastatic patients were actually excluded, and patients that had recurred on endocrine therapy or progressed within a year of endocrine therapy. And again, when we look at all these studies, the question is, is it written in stone, or can you extrapolate for your patient group, right? And I'll get to that. So again, this group of patients had, they enrolled patients that were not diabetic or did not, their HbA1c was under 6%. And I wonder if this patient, they put into consideration patient that had metabolic syndrome, patient that had larger BMIs, right? So these are patients that you start thinking about, okay, these are patients that may be pre-diabetic, and pre-diabetic is not necessarily a number, or maybe patients that have risk factors for diabetes with family history of diabetes or what have you. So again, you start thinking about, okay, is this an appropriate group of patients that you want to get on this therapy? All right, so once they looked at it, they put patient that had mutated PIK3CA mutation on the study. And it's really very, very interesting because it's a very, very interesting study. It's a very positive study, whereby you can see that in the group of patients that got inavolisib versus placebo plus CDK4/6 and the AI of choice, you see that the PFS was 15 months versus 7. So this is a very, very positive study, right? This is a study that you want to ask yourself that, well, what if this patient actually became metastatic 1.5 years after treatment, right? This is a patient I will still go ahead to do this for, right? I've put my patient on endocrine therapy for 10 years and then they call me metastatic. That is a patient I still want to go ahead to see, to check for mutation, to check, so it's just a thing where you start thinking about, well, you cannot literally follow what the study actually has done, because again, everybody wants to be safe when you're writing the study, but then we have to be able to translate it in clinical practice. So again, this is where we start thinking about, for all our patients that were metastatic at de novo, right? Especially for our young patients, are these patients who are going to do worse on systemic therapy? Can you still hear me over there? Right. Who are going to do worse on systemic therapy? Probably these are especially our young patients. I mean, I have a 32-year-old woman in clinic right now, metastatic hormone receptor positive patient at de novo, and she's progressing through everything. And in my head, I'm like, this is a kind of a patient that I would want to see if she has all this mutation and put her on it, right? Again, like I said, this is not pretty much written in stone. Because what we need is, we want to say patient that has PIK3CA mutation. So again, it calls the question again that, all right, what if you have a patient that has PIK3CA mutation and an ESR1 mutation? what are you doing first round? What are you going? And I think we are going to be discussing that later today because somebody asked me that question. I was like, I don't know, VK is coming. So VK, we're going to talk about it as a group to see what are we going to do as a group. All right, so we see that this is 15 months versus 7.3 months. It's actually spectacular. Now, when we see results like this, the first thing I want to know is the side effects of it all, right? Because it's one thing for you to say, well, you have this huge difference, right? But then if the patient is sick, the quality of life is not maintained, then it's not really, to me, it's not a totally positive because study, because then it's positive on paper, FDA can approve it, but honestly, is it positive in our clinic? Is it translatable for our patient population? All right, so in these subgroups, we see that looking at the subgroups, again, everything favor the inavolisib, and we see that everybody is on the Inovo side. And we see that even with patients that have liver metastatic disease, right, or patient that has visceral disease, they actually favored by this therapy. And again, it puts me into thinking that I know that, of course, patient with visceral crisis can be put in this study, but it puts me in a thought process that when you have a patient that has visceral crisis, this might be a therapy that we might start thinking about, right? Because again, patients with visceral crisis, they don't, chemotherapy don't, I just feel chemotherapy just hastens their demise, especially with the side effects. And I know no one is going to be interested in doing this kind of studies in a patient with visceral crisis and what have you. And when I say visceral crisis, patient that we are called on in the hospital. But I wonder if this is proof of principle. We can start thinking about this in this disease group of patient. It's a very rare disease case, right? But we hope that, we can start thinking about this in this group of patients. All right, so the next thing is, what about the adverse effects? Of course, from the CDK4/6 inhibitor, we expect there to be a lot of neutropenia. We expect there to be a lot of thrombocytopenia. So now from the Inovo therapy itself, we expect it to have a lot of stomatitis and hyperglycemia, diarrhea, and yes, they did have that. And I just wonder, how hyperglycemic is it, right? For a patient that is not diabetic, it was able to move them into them being hyperglycemic or diabetic. And then the next question will be, what about a patient that is diabetic, right? Because that is about almost 30-40% of our patients. Are we going to exclude this patient just because they are diabetic? Or maybe we'll just start insulin on this patient and get endocrinology on board. So again, these are the implications for us in my practice, or patients that have a strong family history of being diabetic. All right, but in total, I think the side effect is not something that is not out of the blues or something that we did not expect. It's expected, but I found it interesting that the added side effects, of this combination was tolerable. Because if you asked me before the study came out, I'd be like, nah, you don't want to do that. But it actually did happen, so it wasn't more of a synergistic adverse effect, but it was more of a tolerable one. All right, so the next thing now is, again, on the second line of therapy, right? Because that is the only time when we start thinking about changing the first line of therapy. Then what about the second line of therapy? A patient progresses on CDK4/6 or progresses on endocrine therapy. What do you do next? So when a patient progresses on endocrine therapy, first you want to know if the patient has some ESR mutation or if they have some PIK3CA mutation. And if they have both, again, the question is, what do we do? Right? What do we do first? How do we proceed from here? Right? Or if you give a patient the first line Inovo and the patient progresses, again, the next question is, what do we do from there? Right? All right, so second line here, of course, I've already talked about the first line therapy as far as Inovo is concerned. And then talking about the second line, pretty much, again, we have, if a patient has PIK3 CA mutation, we have choices that we can pick from. Can I talk about my preference or no? You know, because again, as a clinician, what I prefer doing is the least side effects, right? The least side effects and the least clinic time for my patient. So once we kind of focus on that, that's what we keep on doing. Copy I found to have lesser side effect, and that's because it's much more targeted, I think, than Ability Sleep. So, or maybe because here at UIC, I mean, my colleagues are more likely to use that. So for the ESR1 mutation, of course, we have the LSS strand that has been approved on this second line. Again, for the oral sets, initially there was a time where it was just only for first strand, the IM that was just a set, but now we are moving away from the IMs, and now people can just do oral, right? And again, we know that the oral set is a selective estrogen receptor degrader, and we know that it's actually useful in patients that have ESR1 mutation. So the Emerald trial, there's really nothing new here. We know that this Emerald trial looked at patients that had ESR1 mutated patients, and they randomized elacestrant versus the standard of care endocrine therapy. And we looked at the PFS, and the PFS was 3.8 versus 1.9 months. And this has been the second line standard of care. But we have a lot of therapies that have been approved, are going to be approved in this settings. So we have the camizestrant, and this was actually presented in ASCO, the Serena 6 trial. So this looks like at the Cami plus CDK4/6 inhibitor for the treatment of ESR1 mutation. So what they did really was that they actually, this was kind of in the second line, if you will, because they were able to enroll patient that has received CDK4/6 inhibitor as initial therapy for at least 6 months. So they put them on Cami, which continued CDK4/6 and AI of their choice. And all this is just trying to answer is when a patient progresses on CDK4/6 inhibitor plus AI, can we actually move and do Cami? That's just a simple, that's just a summary of it all. And I think that's majority of our patients where they progress. Then the question is, before we move to PIK3CA, can we do something else? So they looked at the primary endpoint for this group, for this study was they looked for PFS. Again, the baseline characteristics is really very important when we are looking at if this patient actually are like the patients that we see in our clinic. And for the most part, again, most of these patients were postmenopausal, which is obvious, but they did have a good representation of premenopausal patients. And there were few of them that had visceral metastatic disease. And then there were some patients that most of the patients had ESR1 mutation, but there were some patients that did not have ESR mutation. And then they were able to look at two groups of patients, the patients that had CDK4/6 inhibitor greater than 18 months or less than 18 months, which was pretty much all comers, really. All comers of patients that could have, that will be in this group, pretty much the second line, or what do you do when they progress after CDK4/6, then what? All right, so what they actually were able to see really is that we saw that there was a huge PFS difference, 16 months versus 9.2 months. So, and again, side effect is always the issue for me, right? There was really no additional side effects that is going to be concerning about us being able to translate this into our clinical practice. Of course, we're going to be having the neutropenia, the bone marrow suppression that we expect to have, especially in this patient population. And at this point, we are really very good in being able to expect and manage our patients with neutropenia and what have you. All right, so what the study really concluded during the last ASCO is that switching AI to Kami with the continuation of a CDK4/6 inhibitor can be possible, especially when the patient has ASR1 mutation. With or without ASR mutation, you can actually switch the AI. Again, it gives us a solid backbone on us being able to justify the continuous use of a CDK4/6 inhibitor or just changing what we call the DAS partner. So, and then again, still in the oral set group, during this ASCO, we also had another vepdegestrant. It's so difficult to pronounce, right? Another ER degrader versus fulvestrant, right? So for our set, everybody has always used fulvestrant because fulvestrant has always been the passport child. But the question is, which is easier? What can we use, especially if it's oral, you know? And again, this study, the Veritech 2, it's a global phase 3 study that actually enrolled eligible patients. The patient may have gotten, again, first-line therapy of a CDK4/6 and endocrine therapy, and they must have been on this endocrine therapy for greater than 6 months. The previous use of fulvestrant was not allowed, or any other oral set was not allowed. So this patient was randomized 1-in-1, and then they got the oral therapy, the FIP versus fulvestrant treatment. And again, the primary endpoint really was they wanted to look at PFS, and then the stratification, the patients were stratified by ASR1 mutation and the presence of visceral disease. So pretty much after progression of a CDK4/6 inhibition, what next? Or the fact that we can, which of the oral sets can we use in place of IM fulvestrant? So for the love of me, I really don't know why we still use IM fulvestrant, because it's a very painful injection. It is. But I think these are one of the things whereby when we look at practice, right? The ability for us to start facing our practices, because when we have a lot of oral sets, why are we still using IM fulvestrant? All right. So looking at the baseline characteristics, again, this was presented in ASCO, like I said. They looked at ASR1 mutation. This why the patients were stratified by that, and then also stratified by they looked at the prior CDK4/6 inhibitors. As usual, as far as patient population, racial population, we didn't have much Black patients in that, but then we are hoping that looking at the real world data, this will help our practice. All right, so in the results that they presented, they looked at the PFS of this study, and what they did see was that vepdegestrant versus fulvestrant was 7.4 to 6.0. All right. And then when you looked at that in ESR1 mutated patient, and then even when you look at that in all patients, in all comers of patient, you see that, I don't know if there's any difference, right, in all comers of patient. But then again, this is more of an ESR1 mutated use. So as far as safety and tolerability is concerned, this is more likely to cause a little bit of more liver damage when you compare to fulvestrant. And other than that, there's really no much difference from the fulvestrant that we have used, apart from the routes with which this therapy is given as far as fulvestrant is concerned. So will we change our practice from fulvestrant to this? I mean, of course, I mean, why not? Again, one of the problems of this, again, is that the QT prolongation. That was the only problem I think we were all talking about, QT prolongation, especially when our patients have nausea and you put them on therapies that will also cause QT prolongation. So we have other targeted therapies with which we actually use in patients that have metastatic hormone receptor positive patients. beyond PIK3AK mutation, beyond ESR1 mutation, what else? If we have patients that blow through all these things, what else? Then we start looking at phase 1 or targeted something mutation, targetable mutation or BRCA1 mutation, germline, the presence of that. So, and then the use of immunotherapy in this group of patients, especially if they have MSI disease. Do you have any questions before we move? Any questions from the room? All right. So, the next, right. Please.
So, your first slide, you listed,
The first one all the way first.
yeah, second slide, the progression treatments. I was wondering, like, what's the timeline? Like, how long do you stay with, I forget the exact, it's endocrine therapy, and then how long do you stay with, you know, each stage? Like, how long is each stage of treatment before the rest of the
So again, when the patient progresses, and progression is defined by RECIST criteria, was the studies that describe progression. In my practice, I define progression by clinical symptoms, right? So once a patient is metastatic already, why am I doing the scans, right? So once I've already established that patient, I just continue to see them. So if they tell me they have any pain anywhere and if they're much fatigued or what have you, then it prompts me to do an immediate scan. So once I do the immediate scan and I see clear progression on a CT scan or imaging, so those are two things. Clinically, they've progressed, and through the image, they've also progressed. So that moves me to the next line of therapy.
So like, when would you see them after you're like initial? Yeah.
Yes, every month or every 2 months, right? So depending on what, in addition to what we're giving them, we're giving them some bone resorbing therapy. So they come to the clinic every month. So when I see them at that point, we can always have that discussion. So give or take, some people progress after 6 months, some people 9 months. I've seen patients that have been on therapy for like the same therapy for 2-3 years and you're still counting. And sometimes some patients have done so well that when I did imaging, I can't find anything. So I de-escalate. So we de-escalate, I take off I first of all start going down on the CDK4/6 inhibitor till it's very minute. And then I take it off and then we'll follow. And then we have the ctDNA, I check it. If it's negative, I follow. And then I just keep them on hormone treatment. And then they come to clinic every other, but it's rare. That is rare. Yeah.
And then my second question is, going to the graph where you had now bolus, and there was like, the 15-month versus 7-month, outcome. What's the dosage of NAV acid? Is it constant throughout
I believe it's constant. I have never used it because I think it was approved, just recently approved. I have not had any patient that came in with that criteria, to use it, but I want to believe it's a constant. And I think the only thing that is not constant, well, palbociclib is not that it's not constant, it's just a on and off treatment.
So they do get like injection shots every so often.
Can you say it again?
So are they getting one treatment and then you look at that progression?
Yes.
Like continually injected?
So I think it's oral, and then the patient comes in for the palbo. Palbo is about 3 weeks on, 1 week off. I don't use it. I use Abamap because I just can't get the on and off thing in my clinic. But the on and off is more of the CDK4/6, but the interval should be all oral, I believe. Am I right, Vicky?
Yeah.
Right. So it's all oral.
Yeah,
And then depending on if the patient is going to be getting ovarian suppression is when you have injection on and off. All right. So now we're on the antibody drug conjugate. So again, we have had a lot of successes in this, especially in HER2-low disease and what have you. And now we have seen that this approved just recently in January 2025, I believe. I thought it was much earlier in patients with metastatic hormone receptor positive disease. All right. So what we actually did see in the Trumpion breast 01 result. Again, this is not, I don't think this was presented in ASCO. This wasn't discussed in ASCO. This is just something that we all know of. But I just wanted to, because there's no way with which we will discuss any metastatic hormone receptor positive disease without talking about ADC therapy. So, and the question is, when do we use this treatment? Again, this is more of a second line treatment for me, because then if a patient has ESR1 mutation, of course, I would use oral set or what have you, CDK4/6 before I use this. Or this again, I would always use in place of patients that have visceral metastatic disease or visceral crisis. I'll use anything before I use chemotherapy for visceral crisis, really, at this point. All right, so we'll be moving to triple negative. For ASCO, I think that sacituzumab govy plus pembro versus chemotherapy plus pembro was actually really discussed in the metastatic triple negative breast cancer phase. And I think this was the one that got the buzz for all of us in the metastatic triple negative breast cancer space. Like I said, the only treatment that the only disease space that was much more buzzing was more of the hormone receptor positive breast cancer. All right, so again, we know that previously when our patients have metastatic triple negative, we want to actually kind of re-stratify them as far as CPS score is concerned. But in my practice, all patients that, regardless of the CPS score, are more likely to put them on pembro with chemotherapy. But then in this study for patients that had CPS score greater than 1 and greater than 10 were said to be PMDL1 positive. So they were randomized 1-to-1, looking at SASI plus pembro versus chemotherapy plus pembro. And then they continued, and the endpoint really was PFS. All right. So the baseline characteristics of this patient pretty much was actually balanced in the two groups. And patients that had de novo breast cancer were also balanced with patients that had recurrent disease within less than 12 months or even greater than 12 months. And all the metastatic, especially with visceral sites, were actually this needs to be pulled. Nicole. So it's going to die. And then the chemotherapy backbone was more of taxanes and gemcitabine and gem-carbo. So okay. All right, so looking at the PFS of this group of patients again, the PFS of this patient was 11 versus 8.3 months. And then when you looked at the subgroup analysis, we see that the subgroup analysis, this is, can you please help me? The battery needs to be charged. I think it's not plugged.
Okay.
Mm-hmm. I don't know why you were saying. I don't know why it said charge, but that's fine. I'm almost done.
Is it good still? No?
I'm almost
Oh,
done.
stay in, okay.
Yeah, let me finish. I'm almost done. So the overall survival is still very immature. All right, side effects again of this. According to the report, there was no addictive side effects from SASI plus pembro versus when you use pembro plus chemotherapy. But again, I would expect that because chemotherapy itself has its own side effect. It's not that it's a placebo backbone therapy that is being used. So as far as the adverse effect of special interest, they looked at the SASI side effects, non-SASI side effects, and compared it with pembro non-side effects, and were able to compare. Of course, the patients, the group with the SASI plus pembro had more side effects than the chemo group. All right, so what they reported really was that Of course, this is the first randomized trials that was able to do without chemotherapy, right? And looked at the use of SASI plus pembro in metastatic triple negative breast cancer, and we see that the PFS was 11 versus 7.8. The overall survival data is still immature, and I think this is a study I'm excited. And I'm waiting on the overall survival. So this will be my last slide. If I have any questions, I think I'm way over time. Way over time.
Double check the Zoom too to see if there's a question
Right.
on here. I couldn't pull it up from my computer. So let me go ahead and double check to see if there is any no chat questions.
Thank you for listening. I really appreciate it. So am I calling Vicky next?
Yep. Yeah.
All right. So how do you get me out of?
I'll pull up BK slides. I didn't see any questions submitted.
Okay. Are you going to introduce Vicky then? Okay.
Just pulling up his slides.
Don't see any introduction. Right. So because of the next speaker, which I would have said doesn't need no introduction, but then I have to introduce him because he signs my check. No, you don't. Right. So I mean, he's the person that makes it happen for us in our department. He's our department top dog, if you will, and then he's the assistant cancer center director, in all I would say. And this last ASCO, everybody that met me, I'm like, oh, do you know Vicky? He's so lovely. And everyone had very wonderful things to say to you.
But then you set them straight.
Thank you. Welcome.
So I think,
You're on Zoom. They can hear you, not video.
okay,
They can see your slides. And they
Okay.
can actually hear the whole room.
okay, perfect. So I wander a bit, so that's just one of the things I do, and hopefully my voice is projecting adequately well here. I think Abiola explained how we kind of got thrown into the mix at kind of last minute, so forgive any errors on the slides and please ask questions along the way. So I was tasked with first of these lectures looking at early stage breast cancer and some of the updates from ASCO, but in order to understand those, obviously we need to anchor those in some of the things that we already know. So there'll be some older data and slides to just build on top of. And these are some of my disclosures, if not current, at least recent. So just kind of from the premise of this is an ASCO update, we have a San Antonio update. So I'm really focused on the last 6 months, just to kind of evaluate some of these clinical advances, how they might impact our standard of care and how we practice, and then how we apply this to kind of what we're doing. I'll start first with EBC, early breast cancer, HER2 positive, triple plus or amplified. I call this now HER2 driven cancers. So just if you pull out the NCCN guidelines, they're mind boggling, right? There's all these arrows and things, but I'm going to super simplify these algorithms. The first question is it small and node negative? If that's yes, we have a standard of care, which is now adjuvant paclitaxel and taxane. That's being potentially challenged, but for the time being, that is the standard. If not, then all those other patients get neoadjuvant therapy, typically with chemo and trastuzumab and pertuzumab, also known as Phesgo. If they go to surgery at that point and they get a pathologic complete response, easy peasy, they get HP to complete a year. If they don't, then we get 1 year of TDM1. So these are the current paradigms. And then the third question is, if it's ER positive, is there a role to think about a TKI that you could use, neratinib? This is it, 3 decision branches. Everybody can do this, right? So let's look at some of this data. I'll start with this. This is the ATTEMPT trial. This kind of snuck under the radar, and I'm going back to 2021. This is a trial looking at whether or not in a small